And I'm getting some private chat, so I'll go ahead and answer that question. Yes, this webinar is going to be recorded and we are going to provide handouts during the webinar. So it will be recorded and we will have handouts. So excellent. All right. So there's some great, we've got some great areas coming in. Some of my neighbors here, so I'm located in Charlotte, North Carolina. So thank you guys. And then we've got a lot of Tennessee, North Carolina, South Carolina. Great. Our headquarters of ICANotes is in Baltimore. So we've got some folks from Baltimore and as well. And Atlanta, nice neighboring city. Great to have you here. New York, Massachusetts, California. Fantastic. Las Vegas, that sounds fun. Simone, that sounds fun. Canada, great. Great to have you. Palm Beach. All right. Looks like some folks are having, if you're having difficulty hearing, April, nice to have you. So if you're having difficulty hearing, let's see, let me just type in really quickly. I bet it's, yes, I bet fun in the evening and a fall. Yes, it's a little hot, right? It is a little hot. A lot of folks from Florida on here, so good to have you as well. I know it's very hot down there, very, very humid. So I used to complain about North Carolina humidity till I visited Florida, and then I stopped. So, all right. So for folks who do not have audio, I did post in there as far as being able, if you sign out of the webinar, sign back in, that should give you good audio. So thank you so much, Sandy, for helping with that. So again, we are in the process of recording right now. So we're recording this webinar and we're also going to be providing you handouts. So, and it's so great to have everyone here today. So again, thank you so much for joining. My name is October Boyles. I'm the Chief Clinical Officer for ICANotes. And one thing before I get off topic today, I really appreciate it if you could list your discipline. I like to tailor my presentations to the folks that are in the room. So if you could list your discipline in the, if you don't mind doing that, you don't have to. You can also do it in private. So if you only feel comfortable sharing that in private, not a big deal. But I do like to know what discipline individuals are, so we can kind of tailor today towards that. So I'm getting a lot of therapists. That's wonderful. Psychiatrists, LPCs, LMFTs. Great. Great. LPCs, LCSWs, social workers, fantastic. Psychiatric nurse practitioners, excellent. All right. It looks like EMDR therapists. All right, fantastic. It looks like we have a good mix in here today. So that's wonderful. That is wonderful. All right. Very good. Thank you guys so much for sharing. This is wonderful. So as we're going to go over tips for writing better mental health SOAP notes. And in the present day, the SOAP note, the acronym for that is subjective, objective, assessment, and plan. And it's the most common and universal form of documentation used by mental health clinicians in patients and client medical records. So the SOAP note really allows providers and clinicians to document, to receive, and to distribute information in a very comprehensive, efficient, and simple to read configuration. And we're going to go into a little bit of the boring history of the SOAP note, but then we're going to talk about the good features of the SOAP note as well and things you can do to improve your SOAP note. So, first off, the history of the SOAP note, it originated from the problem oriented medical record. Problem oriented medical record. And this has been around for a very long time. And there were some limitations to this problem oriented medical record. One, it was kind of like a database and a problem list and a plan of action and notes on the progress, which is similar to kind of the guidelines of the SOAP note. And some people use this method. If you're familiar with that, just type yes in the chat. It's starting to go away. It is starting to diminish a little bit. Now I want to talk about the father of the SOAP note. There's actually a father of the SOAP note, and his name was Dr. Weed, and he passed away. It's over 4 years ago, but he was responsible for introducing this system for organizing patient data in the 1950s. That's how long it's been. So, but and that's it's still used in hospitals all over the world. But he really kind of led the way in developing a computerized method for aiding in the diagnosing and treatment of diseases. So again, it's practically universal in the healthcare system, and it's kind of a way of compiling problems and lists, and was the original SOAP note for creating notes. Now, if you're thinking, I've heard of Dr. Weed before, it's probably not because of the SOAP note content, but he wrote a book. It was kind of a scathing book. Um, it was him and his son, and it's about 280 pages, and it was called Medicine in Denial. And it really talked about some deep disorder that pervades medical practice. And he used a lot of euphemisms like clinical judgment and evidence based medicine. And he really felt like medical practice lacks a true system of care. So, and he felt like it was missing some core elements like standards of care for managing clinical information, and also electronic tools designed to kind of implement those standards. And when he wrote that book, he was he was correct in some of the advances in technologies that he thought were going to be present. And so I believe he'd be impressed if he was still alive. But that is Dr. Weed, and he is the father of the soap note. And he really just didn't like the way notes were being written. He did not appreciate the way notes were written. He didn't think that information was being derived correctly. And so he saw a lot of problems in that, and attempted in his own way to fix that. So now, talking about problems with documentation, let me ask you, what's one of your biggest problems in writing notes and documentation? And you can feel free to just put that in the chat, and we hope we can answer some of those questions. So, what do you feel like some of your biggest problems with documentation are? And then what we're going to be going over next is some tips for soap notes. We're going to be breaking down kind of the soap and digesting that, and according to exactly what should go in to that note or not. Heather says, knowing how much to put into the narrative. That's a good one. Yes. Knowing how much to put in the narrative using clinical language. We'll talk about that. That's good. Putting in too much versus not putting in enough. Yeah, that's a common concern. Absolutely. Time, writing too much, knowing how detailed it could be. Oh, good one. Making sure it's going to meet the insurance needs, right? So you can continue to help support your clients, right? Because they're the ones that give authorization for that. Covering session material, keeping it precise, very good. A lot of too much versus too little. And direct quotes. Oh, we're going to go over direct quotes. I love direct quotes. We're going to talk about that in detail. Past or present tense, really good one. Too much or not information. And length, right? How do we know when a note is long enough? If it's too short, exactly. Writing too much and talking too long. Yes. How to properly show what the clinician is doing in the intervention is very good. How many details? Good. The first note after meeting the client and not always having enough information. That's hard, isn't it? The first note, exactly. Insurance requirements and differentiating between objective and assessment. Oh, we'll go into detail in a lot of detail over that. So great. All right. You guys had a lot of wonderful responses, and thank you so much. Please keep them coming. As you can tell in the webinar, I can't stand when I go to webinars and they're one sided and the person does all the talking. Can't stand that. And so definitely don't want my webinar to be like that. So please chime in. I'm happy to answer any questions. And you guys have already given a lot of great feedback, so that's wonderful. Let's just go through some tips for writing high quality SOAP notes, and then we're literally going to break it down subjective, objective, assessment, and plan. So, some of the things that you put in your comments, it really, we're talking about words and length. So, if you can avoid excessively wordy phrases in writing, you really don't want to write overly wordy notes, and there's a reason for that. There is a reason for that. You want your notes to have enough length to tell the story, but not too much that a lawyer or a patient can read into. All right. So, tell you, and let me tell you a little bit about my background as far as notes and knowing a little bit about lawyers. I worked for many years for one of the largest. It's a law firm here on this in the Southeast, and we represented not patients or clients. We represented generally large mental health hospitals, or large mental health practices. And so we really were helped our folks with lawsuits. And we'll talk a little bit about lawsuits and some of the things that you can do to avoid that and some of the shocking numbers that come along with that. Um, but really, we dealt with kind of helping our clients avoid litigation and also helping close a lot of those lawsuits. So, unfortunately, I served as an expert for that law firm, and I got to see a lot of documentation, a lot of documentation. And you don't want to write too much that people can read into. And we'll talk about how you do that because you're thinking, well, how do I avoid that? We will talk about that. One of the things is making sure the language you use is neutral and not biased in any way. And the problem with today is terminology changes really quickly in today's society. So you need to make sure that you keep up to date with that as far as terminology changes, things like that. But you want to make sure that the note is completely neutral. And we'll go through some examples of that. You don't want anybody to pick up on any bias in your note. And you've got to be really cautious not to make overly subjective statements without being able to provide that evidence to support your claims. And we'll talk about verbatim statements. I love verbatim statements by clients because they really paint a picture of where the client is in their life. And that is their statement. That is not yours. It's not biased if they say it, right? And being clear and concise as possible, the more clear and concise you are, the better. You want to make sure that you use proper pronouns. If you're in a situation where you don't know the pronouns of the client and you haven't talked about that yet, maybe it's your first meeting and they didn't specify, just put they. Just put they. This is a hot button issue right now. And some of the additions to the DSM, the TR, the new updated DSM-5 TR, they have a lot to do with pronouns and the elimination of these. So just put they, especially if you haven't talked about it, okay? Especially if you haven't discussed it. And one you want to, another thing is maintaining accuracy. It's really important that you remain non judgmental throughout that process. And your documentation needs to be written again in a non biased, non judgmental way. And it's really hard to avoid this sometimes because we've all sent out emails that can have certain tones to them, even though that wasn't the intent. This happens in text messages where there are things that are misinterpreted or misconstrued. And so it's natural that this would kind of bleed over into notes, right? But try to avoid that and ensure that your notes are written in a manner that your patient will understand them since they will read them. So, one of the things is you want to avoid abbreviations. And this is where maybe we should pause a little bit and talk about information blocking and what that has to do with SOAP notes. So, who here is familiar with cures and the Information Blocking Act? Just you can type yes, you can type no. We just want to see how many people are familiar with that because I want to know how much time I need to spend on this because this is a big deal when it comes to your notes. So, information blocking or the Cures Act. It was passed last April. So, okay, I'm getting a lot of no's. I don't think I've seen one yes yet. So, all no's. All right, information blocking and the Cures Act is a really big deal. So let's talk about that for a little bit. Okay. I want to slide over to that and then we'll come right back. Okay. The 21st Century Cures Act. So it was actually signed into law in 2016 and it basically didn't come about until 2020. And the Cures Information Act really had a lot of good things in the act. Okay. It called on the healthcare industry to adopt APIs, which will help individuals securely and easily access structured health information, even on like a smartphone. There was a $3.6 billion law providing accelerated cancer research. So there even did a human brain mapping initiative called the Brain Research Advancing Innovative Neurotechnologies. There are a lot of really good things about the Cures Act that helped a lot of people. And that is for the USA only. Yes, it is for in the USA. But just like you think about the way cures, when HIPAA came out, if you think about HIPAA, and that was in 1996, and I was around in healthcare when HIPAA came out, but 1996, it had a lot of good features, right? It made it easier for people to keep their health insurance, but there were those privacy laws kind of embedded in that HIPAA that really caused some issues for healthcare providers, and that's really similar to Cures. Cures is the same thing, has a lot of great initiatives, but there is some information blocking things in there that may provide some challenges for healthcare people. So now this is why you need to write your notes because patients are going to read them because now they're going to have access to most of their notes. And what's happening is patients and your clients are becoming more informed about this new law and their federal penalties for being an information blocker. So some of those go up to $1 million. Do you remember the HIPAA penalties? Well, information blocking, Cures Act, same thing. So you need to know, like, there's some things you need to know. Like, one, you shouldn't be charging for records anymore. That's a law. That's an actual law. Remember, we used to charge for medical records? Nope. That's not, you cannot do that anymore. There are some things that 21st Century Cures Act says you can't be information blockers. The next thing is you have to share certain notes. So you have to share certain notes. And so there are 8 types of notes that must be shared. Now, I want you to think about this from your perspective now. Put yourself in the patient or the client role. There are these types of notes that you see up here that you should be able to see, meaning any lab reports you have access to, pathology reports, discharge summary, HMP, the doctor's note that they write about you. Even if you go in for a stuffy nose, you should have access to view that on your patient portal. And you can request that at any time. You can request any notes that were done for you. So now that you put yourself in the patient client kind of perspective, right? That you can go to your doctor and request any notes at any time. And I know the law just kind of came out, it's a recent law as April of 2020, but let's think about it from the perspective of you can ask from your notes for any period of time. So just be aware of that from you as a patient client. Now let's flip that here. You're the provider. The clients and your patients can do the same thing. So that's the same thing. Um, and this starting in January 2023 is when the information blocking fines are basically going to start. It was a federal initiative. It didn't get a lot of attention or marketing, and most people are not aware. So if you're like, I had no idea about this, do not worry. Most folks don't. So, but as a consumer of healthcare, you need to know about, but also as a provider of healthcare, you need to know about it as well. Now, there are some exceptions for mental health, but they didn't really make good ones. Okay. There are a few. There are notes that you don't have to share with your client. And let's go over those. One is a psychotherapy note. I have included the definition of what a psychotherapy note is right here on the screen. So, okay, it is basically that it's right here on the screen. So if you're thinking, what's the difference between just the regular note that I write on my counseling visits versus a psychotherapy note? Here is this is this is the difference. So that is a psychotherapy note. And that is separated from the rest of an individual's medical record, right? So next are anticipated notes. Anticipated notes, let me give you the brief definition of that. If you are dealing with couples counseling and they're going to have a divorce and your notes could be included in that. If you're working, that's an anticipated note. You anticipate there's going to be a court case. If you are working with a client, maybe it's a juvenile client who has a history of criminal action, that is an anticipated note because that could anticipatorily be used in a court case. right? So these are anticipated notes. These are notes that could be used in a court case against a client. You wouldn't have to share those. Psychotherapy notes, you do not have to share those. Notes that cause harm, meaning if you think that your patient or client is going to read the note and want to hurt themselves, that could be a note that cause harm. Let's think about it from another context. Maybe you are dealing with a young female. She is in an abusive relationship. She has a controlling husband who has her password to her email. And unfortunately, the patient portal is connected to what? When you log into your patient portal, it's your email, right? So you feel like that the husband may get on her patient portal and look at notes that may include details of that abuse, and that he may read that, make him very angry, and he may cause harm to your patient. That is a harm note. So think about it from the context of, you know, would the patient harm themselves or would someone else harm the patient if they saw those notes? So, three different note types that you do not have to share: psychotherapy notes, anticipated notes, again, court case type notes, and harm notes. So, you do have the ability not to share those. But all other notes are free game for your clients, for your patients to read their notes. And for a long time in mental health, we have kind of guarded those notes, right? Because those notes are different than I had a stuffy nose or I have a sore throat, right? These are serious notes that really can affect the way the client, your relationship with your client. Let's just be really honest about that, right? Some of these notes could affect that relationship. So again, if they're these non-shared notes, you're great. But if it's any of these previous notes, um, from these 8 types of clinical notes that must be shared, they have to be shared. Okay. This is really important if you're using an EMR that is not ICANotes, that you have the ability to send those to the patient portal so the patient can view them. If not, you're held as an information blocker, and you do not want to be held as that. Okay. They haven't started again. January 2023 is when they're going to start doling out these fines. So you do not want to be a part of that. Okay. So, got a couple questions here. Do you specify the note or is it just determined after you write it? Literally, you in ICANotes, we have the ability where you can say, like, don't share this note because this is one of the your protected note types. I think it's going to have to be after you write the note, the details of the note, then you did kind of determine, right? Norma says, "How do these notes differ from notes provided to the insurance company?" That's a really good question. Unfortunately, insurance companies weren't included in information blocking. Isn't that nice? There were lots of people that are included. Every single one of you in here, when you listed your discipline, you're included as what the Cures Act calls an actor. So ICANotes as an EMR is an actor. So EMRs are included. Of course, healthcare providers are included, but insurance companies were excluded. Isn't that nice? Yeah. So that's the way things go, isn't it? Yeah. So, all right. Now that I've gone over that, because I think that was key and important, let's really dive into the heart of the SOAP format. So we've got subjective, objective, assessment, and plan. And it's ideal standard to start providing the necessary information. But we really need to take full advantage of how we use this SOAP format. And everybody uses a SOAP format. If you're wondering, it is nurses, occupational therapists, physical therapy, dietitian, psychiatrist, everyone uses a SOAP format. So, and the reason it's so popular is because it helps kind of guide folks as to using their clinical reasoning to assess, to diagnose, to care for the patient, and all of that information provided by them. And so they're really, these SOAP notes are an essential portion of information about the health status of the patient, as well as communication between healthcare professionals. And we're going to break down each heading of the SOAP note. So one is subjective. Now there is this old acronym, and someone asked about acronyms. Acronyms are like you want to be careful using acronyms in your notes, even though old charts isn't is an acronym. But you want to be careful using acronyms in your notes when clients don't understand. Like in the nursing world, SOB is a very common abbreviation for shortness of breath, not what you were thinking. Shortness of breath, right? So there's a lot of acronyms that you want to avoid because if a patient sees SOB in their chart, they may not understand what that means. So, all right. But to cover these conditions kind of systematically and to ensure you don't miss anything, this is a good rule of thumb to follow the old charts acronym. Now, old charts, this is a lot to remember, okay? So, in mental health, most of the time, subjective information is charted in on the chief complaint. And that's what the presenting problem is reported by the patient, right? And this can be a symptom, a condition, a previous diagnosis. It could be a short statement, what the patient's feeling today. If you think about the chief complaint, if you think about a paper, it's kind of the title of the paper. It lets the reader get the sense of what the rest of the document's going to entail. It's the title. So it could be things like, I feel like I want to hurt myself, or I feel anxious, or I feel like giving up. You know, I have shortness of breath, or decreased appetite, or I've been cutting, things like that. It's really the area where the client's own voice comes through. So it's their own voice. Now, when we look at subjective documentation, the very definition of subjective is based mainly on opinions or feelings rather than facts, right? Today, there's a lot of subjectiveness going on in the US, but it's, again, the definition is based mainly on opinions or feelings rather than facts. Now, the definition of objective is it's not influenced by personal feelings or opinions at all. So subjective is feelings, not facts. Objective is not feelings, it is facts. All right. And so in the subjective section, the practitioner, whether that's a nurse practitioner, a psychiatrist, or a clinician, that's a therapist or counselor, you guys are describing the patient or client's impressions and information reported by them and about them, right? So the subjective area should really be about the client stating what's going on with them. And again, I love verbatim statements because those are the best. They're the client's own words. You did not make that up. There is no bias in there. And again, love, love, love verbatim statements by the client. It could be, level of attention, level of engagement. I can tell you, I'll give you an example. I took care of a patient for months, and she was somewhat close and guarded at times. And so hey, I said, how was your 55th birthday? Because she had just had a 55th birthday, and she was very happy. And she looked at me and smiled, and she was as sincere. And she said, I had a great birthday. I did some partying and I tried a little crack because I had never done that before. And it was wild, and I'm not going to do it again. There's my verbatim statement. I had a great birthday, did some partying, tried a little crack, won't do it again. Right? Verbatim. That told that was a picture, that was a story in itself, and anybody reading that note would know exactly what was going on then. So, it's a good example of verbatim statements. As you can see in ICANotes, we have a SOAP note. You can see the subjective objective assessment plan and finishing up that note. And it kind of talks about some of the themes that are going on with the patient and from their perspective, right? So what they're talking about, like feelings of hopelessness are expressed, things like that. So next, let's move on to objective. Objective is what did you see? So it's relevant, measurable information. And again, anything that was taken during that action or interaction with the client. And you really want to consider the objective section as consisting of information that anyone that was watching you, let's pretend someone was in the room and they were observing the encounter with the patient or client that you were having, that they would agree with what you wrote down. So it's quantifiable observation. So, quantifiable observation. And this could be a diagnosis, this could be behavioral or physical findings, this could be an affect that they have when they're talking about situations, it could be their body posture. All right. Those are objective information. Their orientation. Right? What is their orientation? So examples could be like someone says, what did it say? So good. I'm heading right to examples now. So, like the client began to cry when she talked about not being able to find a new job after searching for 3 months, or the client sat with their arms crossed and stared at the floor. Um, those are objective information, right? That is, it's relevant, it's measurable, right? Crying is measurable. It is. Their body posture, that's measurable to what's going on, right? There's something going on with that patient. You're explaining it and you're doing it very well. One of the best examples of documentation was on that I've ever seen was on an aggressive patient, and in a very non-judgmental manner, the writer of the note, the wrote on the paper, the patient whispered, "I'm going to kill you," and raised a pen over this writer's head and moved it suddenly multiple times towards this writer's body in a stabbing motion. That sentence was exactly what happened. It put me right in the room with that clinician, and they did a really, really good job of writing that the patient was trying to stab them in a very non-judgmental, non-biased way. So the patient raised a pen over this writer's head and moved it suddenly multiple times towards this writer's body in a stabbing motion. There was it was free from emotion. It was free from emotion, but it described exactly what was happening during that particular time. So, objective is another clear kind of cut area for you to talk about your relationship with the 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 therapist and the client, or the nurse practitioner or the psychiatrist with the client. You could talk about your relationship there. Again, participation is really big. Is the client participating in a session with you? What was the client's response to process? Another, and if you see on the very bottom of those bullet points there, recognition and review of documentations of other clinicians. So this is really important. How many of you here deal with other entities or other healthcare professionals that you're kind of serving the client with if you're working on a team? So, how many of you work with other, or is it more kind of solo? And if it's solo, that's absolutely fine. So, getting some responses here. Solo. And if you work with other individuals, it's great to have these treatment team kind of practices just to check in really quickly. That is a great time in the objective section to put that you spoke to another clinician and that you collaborated with the patient's care. So, referral records, someone just brought up, Darlene said referral record. You could say that you had reviewed those referral records in detail. So, absolutely. Collaborating with other providers is really, really a wonderful thing. And if you have that in the body of your note, then if you get yourself into a situation, and not that you get yourself in these situations because they happen automatically, and we'll talk about that a little bit later, but unfortunately, but you can then bring in other individuals to cooperate with you, and because they're mentioned in your notes. So that's really, really important. That's a key piece there to kind of help with that. All right. Yeah, referral records are great. I love putting things in the note from referral records. Okay, that's fantastic. And you can put statements as long as you put them in a quotation and said who made the statement. You can actually type from that record into your note. So absolutely. All right. So now let's talk a little bit about let's talk about legality for a certain period of time here. And I know what a lot of you are thinking. You went to school because you wanted to help people. You did not go to school to be a writer. So, and in today's climate in healthcare, everybody is kind of having to practice this defensive medicine, and you have to write your documentation in a way that a judge or a jury would understand it and that you would remember the session or the encounter going back several years. Because a lot of people think like, oh, they just get sued and the lawyer contacts you immediately. No, sometimes people don't even know they're in a liability situation until a year or 2 years in. A lot of them take 3 to 5 years to come about. And so unfortunately, dealing with people who have, I'll say, been the victim of lawsuits, they sometimes they don't even remember that you have a lot of patients or clients. They may not even remember that particular patient or client. So the only thing you have to go on is your documentation to help you remember that incident, right? And so that's why it's using verbatim statements are really good. Using their actions or things that they said to you are really good to help kind of trigger and help you remember these types of situations. Because quite frankly, most people don't remember. They do not remember the individual or the particular person that they served. A lot of people will say, well, like I remember my rowdy patients, right? Or the patients are really complex and I have to deal with a lot. A lot of times those are not the ones that are the liability suits. Okay, so you don't necessarily remember them. And that's okay because you treat lots of people, right? That's your job is to treat people, right? And that's totally okay. But let's talk a little bit about lawsuits. Most plaintiffs, and I saw a lot of you were solo in here, so the are awarded an average of $326,000 in no error cases. I'll explain to you what no error cases mean in a minute, and $765,000 in cases believed to involve medical error. So now, if you work for a facility, those price tags are going to be a lot higher. But basically, what has happened and over the past 3 decades, there's been a lot of different research material that have kind of evaluated the accuracy and fairness of jury verdicts and medical malpractice lawsuits. And the findings are pretty remarkably consistent. So I'll give you an example with physicians. The physicians will win 80 to 90% of jury trials with weak evidence of medical negligence. And that sounds great. Like 80 to 90% physicians will win if there's weak evidence, right? But that means up to 10 to 20% they're not winning with weak evidence. Right. Approximately 70% are on what we call toss up cases. They're kind of like the patient sees it one way, the clinician sees it the other way. So they'll win 70% of those, and 50% of those with strong evidence of medical negligence. So while the numbers are good, they're not good. They're not good compared to the clinician. They're good on the patient's end. So now lawsuits against psychotherapists are on the rise. And right now, 41% of US psychiatrists have been sued for malpractice at least once. That was a study that came out in 2019. 41% of US psychiatrists have been sued for malpractice at least once. All right. So, this is why we're so focused on our documentation. It's the best defense you're going to have in a lawsuit. It's going to be your note. It can sink you or it can save you. And that's why it's so important that you're consistent with it every single time. So, knowing that subjective, again, grabbing verbatim statements, putting that objective information in there. And then someone had said earlier assessment and objective. Assessment is kind of the synthesis of a subjective and objective. All right. This is the assessment of the patient's status throughout the analysis of the problem. And it changes in the status of the problem. So it can be as simple as a obvious diagnostic or a test or a diagnosis. It could cover a range of problems. And it could be if you have lab tests, like if you're doing UDSs on folks, your drug screens, absolutely throw that in there. That's an assessment. Any kind of rating scales. So can be in there. I have assessments like the PHQ-9, the mini cog, the CIWA, the CALS. Those are really, really good assessments. If you have someone with neurocognitive disorder and you're kind of on the fence about what's going on with them, many COGs, MOCAs, and MMSCs are fantastic assessments that you can complete with them to really understand what's going on with them. As far as depression scales, there's a lot of great, good depression scales out there. PHQ-9 is just happens to be one of my favorites. Um, but a mental status exam, that is a formal assessment. A mental status exam is a formal assessment. Um, the other physical exams, and again, recognition and review of documentation of other clinicians, that is an assessment, right? So that's absolutely an assessment. One thing that like folks to do our suicide assessments on every visit. And because I will tell you, it's that one time that you don't do one that a patient may in their life commit suicide. And if you didn't ask, that could be considered as negligent. Okay, so I do encourage people to use really valid and reliable instruments for suicide, such as the CSSR. How many of you are familiar with the CSSR? Heather says there's looks like there's a lot of overlap. There is some overlap between objective and assessment sections. There are some of them, but and I apologize. That handout, I caught an error on that handout that would is up, so we may need to throw up another handout. Sandy, I've found that about 5 minutes before, so we may need to throw up another handout, my current one that I'm using. Because there was Heather, good for catching that. There was the objective and assessment. The bullet points did look the same. Thankfully, they have been changed on this one on this handout. So all right. So CSSR, a lot of you are familiar with it. That is a very valid and consistent, reliable tool. Okay. So and it has really, really simple questions on it, like, have you thought about being dead or what it would be like to be dead? Have you wished you were dead or wished you could go to sleep and not wake up? Do you ever wish that you weren't alive anymore? These are non confrontational questions, and but they will really give you an accurate assessment of what's going on. Another reason I have the PHQ-9 up there is because the PHQ-9 is clinician administered, but it's also can be self-administered. So you can literally give the patient that when they come into your office, or you can send it ahead of time via email, or even better, if you hopefully have a patient portal, they can go on because patient portals are excellent tools, and the patient can complete it, and then it goes directly into the record. So a lot of great things there, but the CSSR is a wonderful, wonderful tool. Yeah, Stella asked, do you administer the CCSR or CSSRS every? I would do it because you can ask that question. It's a simple like one or two questions you can ask them for that assessment. The average time for a CSSR is a 2 minutes. That's it, and it is in the platform. Yes. Exactly. So, a lot of great things there. And ASAM, Laura brought up an ASAM. An ASAM is great. ASAM is a wonderful assessment tool, gives you the dimensions of what's going on. Yeah, it's a beautiful tool. I would put that in assessment all day long. Absolutely. So very, very good. So now, and that's in charting SIP notes, sometimes people get things backward, and it's a common mistake, is distinguishing between symptoms and signs. And symptoms are a patient's subjective description, and they should be documented under the subjective heading. So where a sign is kind of an objective finding. So an example is like if somebody says, give an example. So I'm like, the patient states, I feel really depressed. Okay, that's going under subjective, right? Versus the patient had a PH9 score of 25 that indicates depression, and they're exhibiting body posture and attitude along with facial expressions and general demeanor that could convey their or reveal their depression. So if I say they're having body posture and attitude along with facial expressions and general demeanor that convey depression, that goes under objective. That's me, right? That's one of my assessments. The PHQ-9 score, that's an assessment, right? That goes under assessment. So I hope breaking it down like that helps a little bit more. Um, so now medical assessment, someone asked about medical assessment. Those are very different than mental health assessments. And I truly believe that treating patients with mental health issues actually requires a more disciplined thinking. That's a little bit more rational and open-minded. And let me explain. When you work with strictly medical profession like cardiac care, you have a variety of things at your disposal, like labs and blood pressure, that those are objective. If you get a white blood cell count, it's elevated. Those don't lie, right? If the blood pressure, blood sugar is elevated, there are protocols that you follow that are black and white to fix it. Mental health is all gray. So what worked for the last patient may not help this patient now. But see, in the medical field, if you have a patient whose blood sugar is elevated, you can give them insulin, it's going to bring it down 100% of the time. All right. So, and if you're in this webinar right now and you care for individuals with mental health issues, you know exactly what I mean. So that there's a lot more gray in mental health. And so people that are working in mental health often have to be more creative than those that are in the medical profession. So strictly. And mental health professionals, you guys have a really difficult job because you have to assess, you have to analyze, you have to evaluate without the use of labs and numbers, right? And as you can tell, I'm really passionate about that because mental health professionals, you can't draw blood and tell how anxious or depressed a person is. And every other medical profession has the ability to observe radiology, to do blood tests, to look at blood pressures. They can even do exploratory surgery to figure out what physically is going on. But for a mental health professional, you're just got to observe the patient for anything that can complement or contradict information in that subjective section of their notes. All right, so that was my tirade. That's it. I'm going to skip right over to plan. We're going to talk about the final element of the note, which encompasses kind of the course of treatment. Um, and really, your plan has got to set a clear roadmap for what's going on with that patient. And it should be so clear that another clinician could literally step in your shoes and continue the treatment if they need it. All right. So now the plan is always going to be related to assessment and follow-up visits and progress, and really following that SOAP style is going to ensure that you constantly document the patient's current condition and progress. And, good notes provide documentation that you are following an acceptable standard of care, that you are utilizing appropriate interventions, and you're kind of describing the results of these interventions. And that's one of the good things about with the plan. A lot of people get hung up on the planning part of the SOAP note, and I see that in your comments, right? But really, what your aims and objectives should be are listed here. So, this is the plan between the session and the next, the patient's goals and objectives. And any alterations or treatments are going to be in the plan, right? So, and this could be, you know, for folks that are in here. Um, that are prescribers, this is when you're going to talk about medications you prescribed, right? For folks that are psychotherapists, this is psychotherapy education. Testing could even be in here if you have that coming up. Some of you folks I saw in the beginning are more holistic type providers, so this could be alternative or complementary medical health solutions could be included in here, right? So this is again where some folks work with herbs and vitamins and things like that. That could be the plan of documentation. Folks that are doing, your take your weekly antidepressant, that would be in here. Psychotherapy education, further testing could be in here as well. So that's one of the nice things about the plan. And in ICANotes, you can link in the treatment plan and you can justify level of care, which is really important. A couple folks highlighted insurance. You're documenting to help you remember. You're documenting because that's the best for your client, but you're also documenting so you can continue to get paid on your visits, right? So you're going to add your recommendations in the plan. You're going to talk about your follow up. What's your follow up going to be? Are we going to do weekly sessions? Are they going to come back every 3 months for medication refill? What's going to go on with that plan? And I should be able to literally look at my last note in this section of plan and know exactly what we're going to do, exactly what we're going to focus on for our next visit because it is our plan. It's me and the patient's plan. And a plan is also a great way to put in homework. Like how many of you give homework? How many of you like to give homework? And if you want, you can put the types of homework that you do. But this is one thing that in the plan I can go ahead and create and put this in the plan if they're supposed to do homework and they owe me some homework next week. So that's one of the really nice things about the plan. Looks like quite a few of you do. I'm getting privates and publics on messages. So worksheets, that's great. That's great. That's their plan. They're supposed to do that. And this is another great area if you're continually documenting your plan. Like I gave them homework. They're supposed to come once a week to the session. They're supposed to come back in 90 days for their medication refill. When you have a plan for the patient, a lot of times your patient or client, you may have the best treatment plan for them, the best long-term goals, the best short-term goals, and they're just not going to do it, right? They're just not going to do it. So it's an old country expression. Excuse me, I live in North Carolina, but it's called you can lead a horse to water, but you can't. And you guys know the rest of the express. A lot of you do. If you don't, hopefully someone will type that in the chat. So we'll clear that up. But this is clear in your plan that you're trying to get them to do to get them to where they need to be. It is really up to them though, ultimately, if they get there. And that should be very clear in your documentation of your plan. So, all right. This is a time where I'm going to take questions. I'm also going to show really quickly the SOAP note in ICANotes. So yes, Simone said you cannot make them drink. Yes, universal statement. Yes. So this is ICANotes Plus. So I am in ICANotes Plus. We have several note types. We have progress notes, case management notes, complete evaluations, couple family therapy, but we have SOAP note. And so I'll just run through quickly what a SOAP note. We've got our symptoms there, right? Our symptoms that are reported by the patient. Again, this is where I would type those verbatim statements like, I am very sad. Okay. This is where I would type those verbatim statements. And then I would go in and talk about depression, like maybe they're having concentration problems and they've described that there are periods of excessive worrying. They are feeling hopeless. Jimmy struggles with feelings of hopelessness and maybe struggles with feelings of worthlessness are reported. Then I could talk about current stressors like Jimmy is having problems at work. He has personality conflicts at work and he may lose his job because of it. So that is generally what they're kind of telling you. Objective is of symptoms that I observe. Okay. So symptoms I observe for depression. So Jimmy could be tearful during the session, right? Jimmy could be irritable during the session. So his behavior during the session. Maybe we're talking about like his self care is really reduced. I mean, Jimmy hasn't brushed his hair for a long time and he hasn't shaved and his clothes have stains on them. So I could talk about that. Maybe he needs assistance. Jimmy tells me that he is drinking a lot and that's way more than advised. And Jimmy is telling me that he's not going anywhere and he's somewhat isolated. And then I can move into my assessment. Now, there's our mental status exam where I can go in and talk about like maybe his speech and language is if it's normal, I can put normal. Okay, I can put normal. Maybe his mood, it's depressed. And what do I see? Okay, I see tears and the body posture and some psychomotor impairment and facial expressions. I could say that his affect, it's not normal. So I can go in and say he's flat and blunted in his affect. And he's not psychotic, okay, but maybe he wishes to be dead and he has ideas and intent, okay? And so maybe he denies homicidal thoughts, but if there's cognition dementia issues, I can go in and test for that. You don't always talk about IQ, right, in your session. So you could skip through that unless you are dealing with that. There are folks that test for that. So I'm going to say his insight is poor and maybe his judgment is poor. During these types of, when I talk about judgment, it really is good for you to put things like if you want to, somebody might say, well, how do you know your client's judgment is good? Well, they're sitting here today in this session with me and we're talking about their problems and so their insight is good as well. So you have the ability to kind of talk a little bit more about that. I can say that he has s- some anxiety going on. He's distracted and restless and fidgety and he has poor eye contact. I can move into rating scales and I can talk about the PHQ-9 there and it's moderate. And so I can really delve more into that. And then a plan. Now, this is where justifying level of care is great. So, because I can come in here and say outpatient is still needed because it's affecting his work or it's interfering with his day-to-day activity, is unable to self-alleviate. These are the statements that your utilization review folks and your insurance like to hear. Okay, so there's that. And then one of the best things that I love most about the program is linking in the treatment plan, where I can literally select their treatment plan, select from their problem list, and select interventions and what I want to talk about. Like, we want to identify the causes of depression, and he's keeping a journal. And I'm teaching him a self report scale on that. So, and I can actually link those interventions into my note. So, I have my long term goal, I have my short term goal, I have my interventions, and then what insurance wants to know are the two things. Or how are they doing on their goals and resolving their problems? And I'm going to say Jimmy's doing moderate. Okay. Now, if Jimmy's doing great, good, good, but Jimmy's not doing great. Okay. So we're just going to say he has minimal progress here. And what are you going to do? Well, if he's doing great, we just continue the current plan. But like if he's not doing great, we need more time with that plan, right? So I can attest to that to try to get more sessions or more authorizations or units there because we need more time with this plan. And then I simply link it in to here. Of course, you can put a diagnosis in ICANotes. It's very easy to drop diagnosis in. If you know it by heart, you can just drop it in. F33.1. I can also diagnose by DSM, by code. I'm able to do that. Put service code. Of course, I can put my time spent in, and then I compile and preview. And I have a really nice note that took me very little time to gather together, but it is my subjective, objective assessment and plan. So it looks like I spent all day typing that note, which is really, really nice. So, and then I electronically sign it. So, got a couple questions here. It looks like there are some ICANotes is in answering a lot of questions, so that's great. If there are not questions that I have, if there are the questions I have not answered, please put them in the chat. Are all notes linked for the client to review or as needed? If it's again, so you have the ability to be able to say if the client can see the note or not, because with the particular notes it is a psychotherapy note. Is it an anticipated note? Is it a note that could cause harm? So, and you're justified with the law by saying that, by withholding those notes. Um, so yes, or you can just send notes to the portal. It is. So, all right. I want to get more. One is a nice conclusion here. This is a really nice. I love this quote from Dr. Weed. Um, is religion and medicine is not the feats of intellect; it's helping to solve the problems of the patient and the compassion involved in the very act of care. I love that. So, I wanted to share that with you. We'll do it for questions and. Is there access to SOAP format in ICA or ICANotes Plus? Currently, it is ICANotes. What is my role again with ICANotes, Simone? I am the Chief Clinical Officer for ICANotes. Yep. So I get to be involved in a lot of really nice, all the clinical aspects of ICANotes and compliance. So thank you so much. Thank you. Thank you. Any questions? If I missed your question, please type it in the chat because we do have just a minute or two. And I want to make sure that I get to all your questions. And I apologize with the handout mishap. We will correct that. So let's see. Thank you, Tammy. Thank you so much. Thank you, Renee. Thank you. Um, thank you, Janet. I work with a different platform. Can I get the information from ICANotes without? So I think you're saying, can you copy and paste from ICANotes into other platforms? You absolutely can. If that's not what you mean, please type that, and I will definitely. Joan says, how can I learn clinical language? That's a really, really good question. So with ICANotes, we already have the clinical language embedded for you. But here's the caveat with that. Um, so with the new Cures Act, they're asking people to write in less clinical language, for language that the patient will understand. And that applies mainly to medical because, they have a lot of ambiguous language there, but it also applies with mental health. So, no prob thank you so much. Thank you guys so much. Um, I can I get a copy of the presentation? Absolutely. Everyone that's in here, we will be sending you out the video. So if you want to rewatch it, share it, absolutely. We're also going to send out handouts for sure. And the soap note, yes, is in ICANotes Plus, and it is ICANNOTES Plus. Will this training be available after this class? Yeah, so we have a lot of really wonderful trainers that are in here now that will absolutely train you on the soap note. That's one of the beautiful things about ICANNOTES. Training is free and unlimited. So we make sure that you really know the program, and we have a lot of wonderful trainers in here now. I see them in here, so they know how to do the soap notes, and they can teach you how to do that. Absolutely. Yeah, Teresa, you can. Yeah, we can definitely talk to you about that. What's the difference between SOAP notes and the progress notes? So progress note in ICANNOTES is laid out a little bit different. I'm happy to show you that. The progress note goes more, it's not in a SOAP note format. It's just kind of in a bait. And a lot of people really love SOAP note. I'm a huge fan of the SOAP note because I think it keeps clinicians on track with a SOAP note, but other individuals don't use soap notes and they like just a progress note where you're talking about, client has symptoms of, and maybe they don't have symptoms and their behavior is normal and their mental status is normal. And then I can have like their verbal content and I can talk about that. Like, Jimmy has problems in his relationships. He's just not good with that or intimacy. And he has depression and guilt and shame, and we'll throw a little chronic pain in there. And then it talks about our therapy interventions. So those are some of the things. If you don't want to follow the soap note format, again, I'm a fan of the soap note. So absolutely. Let's see. Maria, I want to make sure I get to you. Maria raised her hand. She is one of our wonderful trainers. Um, do we have a template for soap notes? We can create a template. Yes, absolutely. Absolutely. Can I email the report that I did today as an example? Like the notes, I absolutely can. We can throw a SOAP note sample on there. Happy to do that. So thank you so much, Candace. Thank you. Let's see. Is iCanvas Plus available? It is. Yeah, Jacqueline, both notes are good for insurance purposes. Let me tell you the main thing that you need to do with insurance, though, is that justify level of care. That is going to really be instrumental because people forget a lot of times to say why the patient continues to need therapy or why they continue to need medications. We talk a lot about why they need them at the time, but not the continued need. So, yes. Thank you. Thank you, everyone. Thank you so much. If you have any questions, feel free to reach out to us at ICANotes. So we are, and I'll direct you to our website because this training, I believe, will be put up there as well. But it's ICANotes.com. It is ICANotes.com. So thank you to everyone. I really, really appreciate your attendance today and your participation. It was absolutely fabulous. Thank you. Thank you. Y'all take care. Bye bye, Simone. Bye bye. Y'all take care.